Hello, everyone. Welcome. First, I wanted to thank Dr. Beamer for joining us today. We all appreciate you being here, and we're really excited to learn from you today. Today's event is going to be interactive, so please feel free to raise your hand at any time to ask questions. You can also turn your video on, and this session will be recorded so you can watch later. But Dr. Beamer is a Harvard and Stanford trained orthopedic surgeon serving the greater Sacramento area and Sierra foothills. Dr. Beamer specializes in sports medicine and joint replacement and has served as assistant team physician for the San Francisco 49ers and Stanford Athletics. He performs advanced arthroscopic surgery of the hip, shoulder, and knee, and is one of the few fellowship-trained hip arthroscopists in Northern California. He also performs hip replacement surgery through a less invasive, muscle-sparing, direct anterior approach. I personally worked with a lot of Dr. Beamer's patients at a physical therapy office, and all of his patients had a positive experience under his care and were able to get back to their activity of choice, whether getting back to professional sports after an ACL tear or getting back to hiking after a total knee replacement. We like to say that Dr. Beamer saves lifestyles, getting patients back to the activities they enjoy. Please welcome Dr. Beamer.
Awesome. Thanks, Jenny. Good to see you again. And thanks for taking time out of your day, everyone, to learn a little bit about musculoskeletal care. So I'm an orthopedic surgeon. I was largely molded by my early experiences. I think what you get exposed to early in medicine kind of paves the way for what you kind of end up being interested in later. So my father had a couple of orthopedic surgeries on his knee, and I started in college shadowing his orthopedic surgeon in downtown Sacramento, and really liked the arthroscopic approach, doing less invasive surgery. I also saw him do some joint replacement. And it was cool. He'd bring me in on the half clinic day, half OR day. So I got to see the intricacy of the surgery and then go to the clinic in the afternoon and see how well his patients were doing. And I was impressed by the fact that a lot of the follow-up visits were conversational. It's like, hey, how you doing? It's like, I'm great, doc. I'm back to work. I'm playing sports again. Like, this is great. Thanks so much. On the contrary, I shadowed a general surgeon at the same time and saw a patient almost die on the table. And I was like, whoa, this is a little intense, you know? I was sitting there squeezing bags of blood into this kid who was having a routine appendectomy, but somehow the common iliac artery got nicked and started bleeding out and had to open him up. And it was intense. So I think when you're making your decision on what you want to do, I think there are some folks that are, the kind of the big fork in the road is medicine or surgery, right? And then within surgery, it's, do I want to take care of sick people or healthy people? So when I was in high school, I watched my grandmother wither away from pancreatic cancer, which is a terrible, terrible disease, and kind of knew that I didn't want to take care of the, super sick or super ill. So then that led me down the pathway of like orthopedics or plastic surgery or dermatology or things like that. And I think every field has its culture. And I felt like the culture of orthopedics kind of resonated with me as a former athlete and outdoorsman. And, I'm always active and doing stuff, and it allows me to connect with my patients. Whereas when I was at med school in New York City, I'd go to the plastic surgery conferences, and all these plastic surgeons off Park Avenue would come to the conferences in the evening to remain academic. And they had highlights in their hair and Botoxed. And I was just like, I don't think these are my people, So anyway, but that being said, would 39-year-old me be comfortable doing plastic surgery? Yeah, absolutely. But anyway, what I like about orthopedics is we treat the whole body. So I treat from basically head to toe, young and old. So you really have to be an expert anatomist. You have to really know the anatomy, because really what we do in orthopedics is we restore anatomy. So somebody has an arthritic joint that's malaligned. We restore the anatomy by resurfacing the joint with an arthroplasty and restoring the natural alignment. So, or tendons like an ACL tears, you got to put it back, and not only put it back, but put it in the right spot so it functions the way it's supposed to. So really, I loved anatomy in medical school, and being able to not just focus on just the belly or just the chest, or whatever, or just the foot, like if you did podiatry. I don't know. I like that aspect of it. So there's a lot of ways that you can get involved in musculoskeletal care, though. You don't have to do an orthopedic residency, which is 5 years plus 90% of people do a fellowship. So you're looking at a decade of schooling after college, right? You guys are already starting that route with 4 years of medical school. Now, the question is, how long do you want to extend that training? So other ways to get into musculoskeletal care besides orthopedics can include plastic surgery. That overlaps with orthopedics and hand surgery. Neurosurgery overlaps with orthopedics and spine surgery. And then obviously you're going to medical school, so you're not going to go into podiatry school, but if you find that med school is not for you and you still want to do musculoskeletal care, that's an option as well. Other ways include some non-operative, so those are all operative things I talked about. Non-operative ways to care for people with musculoskeletal ailments include a field called PM&R, or physiatry. And PM&R is an acronym for physical medicine and rehabilitation. And a lot of those providers are super skilled with the ultrasound and can do, percutaneous tenotomies or needling techniques or various guided injections, and deal with a lot of people that have musculoskeletal ailments and joint problems. Some get really heavily involved in spinal cord injury rehabilitation or helping patients of trauma. Some specialize more in the back. But when I was at Mass General, we had super good physiatrists that really interfaced well with the orthopedics team, and she helped take care of professional athletes and all sorts of things, because not everyone wants to see the surgeon because they know what they might end up with. They might end up with surgery. So oftentimes we use our colleagues that are really good at the non-operative techniques to try to bridge the gap. And surgery should always be the last option. There's a lot of good modalities between, say physical therapy and just general health, and then, go into surgery. Another way to get into sports medicine is either through emergency, residency in emergency, or family medicine. You can go in and do a primary care sports medicine fellowship. And again, in many ways, doing a lot of what PM&R does, but maybe a little less intense. Another thing that PM&R does that reminds me, one of my colleagues just became a PM&R over in Folsom. They also do a lot of nerve conduction studies. So again, so in medicine, for one reason or another, procedures pay. So, doing guided injections, doing percutaneous tenotomies, nerve conduction studies, there are a lot of things that you can bill for in PM&R. Doing diagnostic ultrasound as an imaging modality, all those things you can charge for. Family medicine and family practice sports medicine, I don't think does nerve conduction studies or is certified to administer those or interpret them, and those actually reimburse fairly well. It's not all taking care of athletes and taking care of healthy people. I mean, I just saw 3 pre-op appointments today for total joints I'm doing on Monday on older people, but some of those can be some of the most rewarding surgeries. Like when I do an anterior approach hip replacement, those are a slam dunk. People get better super fast. A lot of them go home same day. Every now and then we got to deal with things like diabetic feet that, when you're on call, and like I had a homeless guy come in and there was maggots in his feet and had to cut off a good portion of his foot, so that's the less sexy part of orthopedics, but still super important. So anyway, I don't want to ramble on too long. I just wanted to kind of tell you like the routes to getting into musculoskeletal care. Another way is musculoskeletal radiology. If you love the anatomy, but you don't want to deal with patients and you still want to do some procedures, musculoskeletal radiology is great. You read MRIs all day. You can do invasive procedures, various injections. Some radiologists even do spinal procedures. So a lot of ways to take care of the musculoskeletal system that don't necessarily involve doing a surgical residency. So if you guys have any questions for me, like how do I get into orthopedics or how do I do this or that, feel free to let me know. I mean, orthopedics is pretty competitive, but there's no shortage of orthopedic needs. So we're always going to have a demand for orthopedic surgeons, but like obviously doing well on your boards and all that is important. Getting good grades, doing some research, getting in with some mentors that can advocate for you when it comes time to apply. I mean, it's a small community. So if you have a letter of recommendation from somebody that is known in the community, by chances are the chairman of the place that you're going to apply to may know that person. And the deciding factor between two applicants with good grades and good scores might be the word of mouth recommendation from a friend or colleague that they know and trust. They're like, well, I like Dr. So-and-so, and if Dr. So-and-so likes this kid, then chances are they're a good person, you know? So, so just getting connected in the community by, you know, getting involved in research or going to meetings and starting to get to know people is important, because even though there's a lot of orthopedic surgeons in the country, we see each other a lot at meetings and stuff, and we've all crossed paths at some point. So like today, I just referred a shoulder guy to a patient down, or to a colleague of mine down in Newport Beach. You know, it's hours away, but I just sent him a text and said, here's this guy's demographics. He's coming to see you, you know, and just, so it's a small community. So getting plugged into the community can be helpful. Anyway, when I studied for my, you know, it's hard. Like the boards are always changing. I don't know aren't they going to pass fail for step one now? So like back in the day, we had to get like a really good score to get, like anything above 240 was like considered competitive for orthopedics. So I took off like 6 weeks from school. And they gave us 3 weeks to study. So the last semester, I kind of stopped going to class the last 3 weeks. And I studied 14 hours a day in the library for 6 weeks. I did a half day on Fridays just to keep my sanity. But, you know, it ended up paying off. I got a super high score, and that helped me get into orthopedics. But back in the day, that's what you had to do, you know. That was like, that getting that good score on step one was, I think, kind of your foot in the door, because you got to make it past the secretary screening all these apps, you know. But anyway, it's changed now. So I think now that it's pass fail, you have to do even more to distinguish yourself by getting involved, trying to publish. You don't absolutely have to publish a study. I don't think, I published a couple things in med school, but they weren't groundbreaking, you know. But you know, being at a medical school where you don't necessarily have a dedicated hospital right across the street makes it a little bit tougher. But being in, you guys are in Vallejo, right? Is that where the campus is? So, I mean, there's plenty of opportunities, even at Kaiser Oakland. Like I got a buddy who does a bunch of hip arthroscopy at Kaiser Oakland. They do research, you know. UC Davis, obviously UCSF and Stanford are not far away. Even if you're just doing like a summer project or just you can do a lot of stuff remotely. They may, you know, get to know someone. They're like, analyze this data, look at these x-rays, score these, blah, blah, blah. You know, like that's a lot of studies I did as a medical student, you know, just kind of piecing together the last parts and getting your name on a study. So anyway, you gotta seek out the effort, or seek out the opportunity rather, make the effort. So if anyone wants to ask any questions, go for it.
I wanted to ask Dr. Beamer if you could talk a little bit about your life outside of the OR. You do a lot of fun things outside of the OR too. So if you could talk on this.
Yeah, I mean, I'm a work hard, play hard kind of guy. Like I'll work my butt off when I'm at work, but when I'm off, yeah, I'm out of here, you know? Here, thank you so much. Yeah, so I am busy enough that I started taking Fridays off. If I'm on call though, I'll do some surgery on Friday afternoon because I know I have to be around that weekend. So I work 4 days a week. Sometimes those days can be done by 3, sometimes it's done by 9. You know, it depends on what comes in and when I'm on call and how long the cases go. But outside of working, I'm an avid outdoorsman. I like to bow hunt for elk. I fly fish. I was just fly fishing all weekend up on the Trinity River. I mountain bike, I snow ski. I just kind of live this Northern California lifestyle, you know. I'm not a big golfer. A lot of doctors are golfers. I'm not great at golf. I figure if I'm going to frustrate myself with something, it's with fly fishing. So, but yeah, I mean, I think it's good to practice what you preach. You know, you're telling these patients, you know, you need to lose weight. That's why your knees hurt. And if you're rolling into clinic 300 pounds, like it doesn't really set a good example, you know. And then, you know, being able to connect with my patients. Like the last guy I just saw right before I talked with you guys was wearing a Hoyt archery hat, which is one of the big bow makers. So we started talking about like shooting bows and, you know, just like little things just to connect with your patients, you know, just helps bridge the gap, add that like human aspect. But yeah, and you know, you can cover like, you know, ski teams and work at a ski mountain, get your family free ski passes, you know, by covering a couple weekends a year. There's just a lot of things. People always want orthopedists around, you know, because people are always breaking stuff. So Anyway. What else? What else? What other burning questions do you have?
Looks like there's one in the chat. I can read it out loud. So it says, since DO students do tend to have a more difficult time getting into a specialty than MD students, is there anything you suggest we do to boost our chances of being competitive amongst MD applicants to orthopedic residency? I know you're an MD yourself, so I'm not sure how much you know about the DO path to orthopedics, but maybe if you have some general advice about making ourselves as competitive as possible.
Yeah, actually, I just sent my dad to a DO surgeon to replace his hip in December, and he did great. Jeff Bergeson up in Auburn is a DO. He built custom homes and decided he wanted to go to medical school at age 40 or something like that. And so he's not non-typical applicant and ended up, I think he might have gone to Touro for all I know. But I know that there are DO specific residencies, a lot of them focused in the Midwest, like in Michigan and whatnot. I know plenty of great DO orthopedic surgeons. I think it is, for one reason or another, I don't know if it's always justified, but just a little bit more of an uphill battle. But I think if you can prove yourself to an orthopedic department by being a go-getter, like showing up, doing research, helping out with projects and getting to know the right people, that's what you kind of need to get your foot in the door. Having a personal connection. Don't just be another piece of paper with a good score and good grades, behind your name. Having some really strong letters of recommendation and trying to do the right things, whether it be for PM&R or ortho or emergency med, just kind of getting involved in that community and showing your dedication to the field, and then having some robust mentor support, I think is paramount. It's not just scores and grades anymore. It's just hard. Again, the thing I think, like, I've talked to some kids from what's the new school, Cal North State, like down in Elk Grove. It's a new allopathic pathway school, but again, not associated with a research institution or hospital or anything. It's kind of an uphill battle, you just got to go out and seek out opportunities, and you might get 10 no's and then finally get a yes. But yeah, there's always research to be done, especially you guys are not far from UCSF and Stanford, or even Davis for that matter. There's plenty of work to be done, and just getting in with the right people. Maybe try to do some research with the residency director or somebody that's, connected with teaching, and that, is not just going to be like a lab rat guy that's not going to, or gal that's not going to really write you a solid letter, but somebody that's got some connections, who's well known, is maybe involved in the different societies, kind of do your due diligence, do a little research on them, but find somebody who's active and like not just at the tail end of their career, just, publishing, that's what I would say. I think just making those connections is what's going to get your foot in the door and get you the interview. And then when you get the interview, you're going to knock it out of the park and you'll be good, In terms of finding these opportunities, would you suggest cold emailing residents and attendings? What else does Eddie say there? Oh, I can bring up the chat. I think what I would do is, it's tough. You can certainly do that. Try to see if you get a response, but maybe start with like, I'm gonna have to think on that for a minute. Like, what's the best way to not be like annoying, but like get a response, don't bother the residents. They can't help you. They're too busy. You need to get, I would seek out initially, like maybe some of the more junior attendings that are maybe getting some research stuff up and going. They might have more availability of work to be done. You could also kind of reach out to the residency directors or every residency has an administrator that's like the chief administrator for the residency. They're like the quarterback. They quarterback everything, all the licensing and credentialing and run interview day and all that. That would maybe be a good opportunity as a foot in the door, and they can maybe send out an email to the attendings and say, hey, I have a student who's interested in getting involved in orthopedic research. Is there any need? Like the lady that was our lady at Harvard was Diane Sheehan. Now it's somebody else, but there's always somebody. Like if you go to the website and you look at the residency, there's going to be a contact person, and that's going to be the administrator. and then just let them know that you have some interest and you want to get involved and see if there's any opportunity. That'd probably be the best middleman. What would you say is the most rewarding and difficult part in my specialty? The most rewarding part is, orthopedics is cool because you get a lot of immediate gratification in the sense that like somebody comes in, their ACL is clearly torn, right? And then you put a new one in and you take photos of it, with your camera. You're like, hey, look, it looks perfect. High fives. This kid's going to do great, and then seeing them and follow up. Or a bone is broken and it's shattered, and then you take x-rays the whole case and you watch the progression of taking it from shattered to being fixed, and so that I like to it's very tangible. You can feel things, you manipulate things, you reduce fractures, you reduce dislocated joints, and you shoot an x-ray and it looks great. And it's like, hey, I put it back, I fixed it, versus like in medicine, somebody's got, hypertension, you make a slight adjustment to their med and you follow it up 2 months later, 3 months later. It's a little bit better, than you add on another med and then you follow it up another 3 months later. I mean, you obviously help people a lot, but it's just a little bit more delayed gratification. I'm more of like, hey, let's get it done and let's take a look at it kind of thing. So I would say that's rewarding. The toughest part is there's no shortage of work. Like I got people texting me, like I got multiple text messages this morning from other doctors like, hey, I tried to send a patient to you. They said that you're booked out till the end of April. This guy's got a fracture. Like, can you get him in? I'm like, all right, well, I got 35 patients booked every clinic day and I'm here, so it's like a blessing and a curse being busy and having a busy practice, but there's plenty of work to be done. But that leads to some long days sometimes. And call is tough. Like, having a largely elective practice doing sports medicine joint replacement, I can kind of choose my patients. If there's somebody I'm like, I'm clearly not operating on this person because they're a difficult patient or whatever, I can refer them out. But if that patient falls and breaks their hip and I'm on call, I got to take care of them regardless, So you get all comers. Some patients are better patients than others. Some want to do the right things and heal right. Some don't want to stop smoking or, control their diabetes, and then they end up with complications, and it can be tough. And then, like the call's unpredictable. You don't have to take call though. Just in my current employment situation, I do take call, but you don't always have to. It depends on your agreement with the hospital and what you got going on. But yeah, the call sucks. Yeah. Other call that can be tough is like hand call. Like if somebody cuts off a finger and you got to be available to reimplant it, like at some of these major hand centers. And then spine call can be tough if somebody's in a motor vehicle accident and breaks their neck and you got to fix it in the middle of the night, to protect the spinal cord. That can be rough. But yeah, I mean, don't get me wrong. Like it's a pretty sweet job, honestly. Like it's not terrible. It's just there's a lot of work to do, and sometimes I mean the work can be labor intensive. I'm swinging a mallet, like impacting a total hip, and like all of a sudden my shoulder's a little sore. So I'm like, okay, what can I do? Maybe lower the table so I'm not up here hammering it in, so I don't jack up my shoulder because I got to do this for a long time. Or like lifting a heavy patient and you tweak your back. You just got to be careful, So there's a little bit of labor intensity, but I would say if something is hard to do, if you're having a hard time putting in the implant or moving things around, then you're doing it wrong. Like it should be, because there are plenty of small framed women that do what I do, even replacing joints, and they find ways to use mechanical advantage and they get creative with. Like I remember this one how she taught me, she was small, like how to reduce the shoulder. She would wrap a sheet around her waist and then wrap it in the crook of the elbow and like just lean on it with using her body weight. Whereas us guys would just be like, using brute force, which is, I'm like, well, this is so dumb. Like, why? This is brilliant. I love that sheet trick. So like I do that now, so you learn little tricks from people, but it can be labor intensive. And then the training can be long, but luckily it's not, you're not dealing with death and dying. 5 years of orthopedic residency, I think is appropriate because like I said, you work on the whole body, So anyway. Let's see what else. Can you speak about PRP and stem cell therapies or any other therapies using to improve recovery time after surgery? So the term stem cell is being totally cracked down on by the FDA because a lot of these regenerative medicine clinics, many of which are run by chiropractors or people that are really not medical doctors, are doing all these cash pay procedures and telling people they're giving them stem cells when they're really giving them nothing that's biologically proven at all. Like embryonic, like they were doing these like amnio injections and saying that there were, embryonic stem cells in there and this and that. First of all, those fluids have no viable cells in them. And even if they did, we all know how the immune system works. The T cells are going to recognize those foreign cells and just wipe them out. Now they are, that fluid is full of growth factors and other things that can help, but I use PRP in my clinic. I use it for arthritis. So it's been shown to help with knee and shoulder arthritis, or any joint arthritis for that matter. I use it for tendon injuries like tennis elbow, patellar tendonitis, rotator cuff tendon, partial thickness tears, things like that. It helps. I tell patients it doesn't necessarily burn any bridges. It's not going to make you worse, but it can only help. Now it's not covered by insurance, so I say, it's a gamble. You're investing in your health, but it may not help, but it may not make you worse. And there's level 1 studies showing that, like for arthritis and different tendinopathies, it actually is superior to, say, hyaluronic acid, which is the gel that we put back into knees to help kind of cushion the joint, or cortisone. And then for stem cells, the 2 places to get mesenchymal stem cells are the bone marrow and the adipose tissue. And most Americans are like, well, I got plenty of adipose, so why don't you go ahead and take some of that? So I do a procedure called lipogems, which I do a little liposuction of the tummy. Like if I'm going to scope a knee, I'll do that in the beginning and then position the patient, prep them up, take about 100 cc's of fat, which actually isn't that much. And then we mechanically break down the fat with this big vial that has ball bearings in it. This was developed by a doctor in Italy, a plastic surgeon, and you shake it within saline, and it mechanically breaks up the adipocytes, and then we wash away all the lipids, but the perivascular pericytes are in the stromal fraction. So we preserve that stromal fraction after filtering it and break that down and then inject it into the knee or the shoulder or whatever. And I've used that a lot in patients. Like I got like a cohort of like 50-year-old patients that are too young for a shoulder replacement, but they've been lifting heavy weight in the gym their whole lives and they've worn out their shoulders. And I go in and clean out the shoulder joint, release some of the capsular tissue to give them more range of motion. Maybe retrieve some loose bodies and then put the lipogems in there, and a lot of them are doing really, really well. So, it's kind of a bridge. It's not going to be the panacea where we're going to make, cartilage magically reappear on these arthritic knees. I don't think we're there yet. But the way I present it to my patients is it's going to improve the environment in your knee and introduce some positive factors that can help slow down the degradative process and hopefully slow down the need for a joint replacement. And a lot of patients come in just wanting to absolutely avoid joint replacement at all costs. So I use it as a bridge. I don't make any false pretenses that it's going to make the space on the X-ray increase or anything crazy like that. But I've been surprised with how little pain medication these patients need after surgery. Their joints just don't hurt. And it's been, they're going to go somewhere to get it. And I figure a qualified musculoskeletal specialist should be administering it rather than some of these knockoff clinics. So, but there's definitely a role for that. It's continuing to expand, and a lot of non-operative sports medicine specialists will also do some of these orthobiologics, is what we call them, some of these orthobiologic therapies. All right, so let's see, that I worked with the 49ers at one point. So I did help take care of the 49ers while I was at Stanford as one of the 3 sports medicine fellows that year. So I did all my training back east. So I went to Berkeley undergrad. I grew up in Rockland, California. I'm from the Sacramento area. And then I applied to medical school all over. I applied to like 52 medical schools or something crazy because I only wanted to do it once. And just like, I was taking a year off at the time. Back in the day when I applied, you could only take the MCAT twice a year. And I was going to be gone that whole summer between my junior and senior year doing this philanthropic thing that I was doing. And so I said, no, I'll just take a year off and do some research, buff up my CV and whatever. So since I had the year off, I could do all those secondary applications and stuff. I had the time, so I was like, I'm just going to spread, cast the net wide. So I ended up going to medical school at Cornell. and that was great. They have a really strong orthopedic hospital there called the Hospital for Special Surgery. So like my first week in med school, I had already graduated with a degree from Berkeley in biochemistry. Like the first semester of med school was like repeat. So I started going over like doing research and scrubbing into surgeries and making those personal connections we talked about. So then I went up to residency in Boston, and then I drew a line in the sand, and I was like, I want to go back to California. Like I've been back east for nearly a decade. So I only applied to fellowships in California, and I wanted to learn hip arthroscopy better. I mean, I had been introduced to it in residency, so I wanted a hip strong fellowship. I wanted to take care of a professional team, and being a NorCal guy, like I grew up watching the Niners play, and they used to have their summer camp at Sierra College in Rockland, so we'd go over there and watch them train. So my goal was to go to Stanford, learn how to do hips, and take care of the Niners. And that all worked out, and they asked us once we were accepted, hey, like, what teams do you guys want to take care of, rank it? And I said, I want to take care of the Niners. Like, I'm a NorCal guy, like that's my team. And so I got to do it, and it was cool. I mean, I worked with Dr. McAdams and Dr. Fanton, the team doctors, and would be there on the sidelines at the games, go down to practices in the afternoon. Once the team got comfortable with me, like I would cover the training room on Wednesdays by myself, would work up players and stuff and decide if they needed an MRI or an injection or anything like that. And it was cool. I mean, it sounds cool, but you gotta realize like being a team doc is like, it's tough because you have to answer to the media, you have to answer to the players, their agents, the training staff, the coaches. Like it's a very political position, and if any one of those elements feels uncomfortable with what you're talking about, they're either going to go get their care elsewhere or you're not going to be the team doc anymore. So you gotta kind of make sure you talk to everyone's different concerns. The coach may be like, when can we get this guy back? And the agent may say, hey, you know what, this guy's got a long career. I don't want to see him come back too early, and then screw up the rest of his career. So then you gotta it's a lot of work. And then you're like constantly on call for the team. I mean, like traveling every weekend from August to January is kind of rough, So I didn't have to go to all the away games when I took care of the Niners. I did fly to Detroit and a couple other places, but sometimes when they were playing away, like that's when I got to go fishing or just enjoy the bay, got the weekend off. So it's cool. It's a great way to build a practice. Does it pan out from like a financial standpoint, the time away from your office and your patients to be taking care of this team? Probably not. So it has to be a labor of love. You got to really enjoy it. But yeah, it was a great experience. I always tell my patients, like, look, I don't take care of pro athletes anymore, but I'm going to take that same level of expertise and intensity and apply it to your case and treat you like I would any of them. And I think that resonates with people.
Can you speak a little bit more to how you collaborate with other physicians and physical therapists, et cetera, other practitioners to get the best care for your patients?
I think the best way is just to like be a good colleague and realize that everyone has something to offer, whether it be the non-operative person who has done everything possible to get, their patient better, and then they can't, then they're turning to you to say, hey, look, I've done all I can, like this patient needs a joint replacement or whatever. Like you gotta, be super appreciative and communicate with them. And then if they're trying to manage the patient non-op and they want to consult with you about maybe other things they could consider, like be a resource, because eventually when that stuff stops working, they're going to send you the patient if you're a good person. And I think just being available, somebody told me the three A's of successful practice, and they go in this order of being available. So, giving out your cell phone number, returning people's texts or emails when they text you, being affable, being likable, being a good person, and then being able. You got to be able to do your job and do it well. But able is third. Okay, it's not first. It's availability. Like if you're not available to referral sources or your patients, they're going to go somewhere else. So you got to find, like what I'm trying to figure out at 6 years in practice is what's that work-life balance? How can I be available for my patients, but also be available for my wife and kids and for myself, So you gotta strike that balance. And then you gotta be a nice person. Like some docs are awesome technicians, but terrible bedside manner. Like I'm thinking of this one hand surgeon I refer patients to sometimes. I just pre-warn them. I'm like, look, he's a good surgeon. You're not going to be super impressed with his bedside manner, but just listen to what he has to say, you know? And so, you know, some people can get away with that if they've got they've been doing it a long time and they've got an established, reputation. But I think just being a good person, being super appreciative, sending thank you cards, collaborating with people, getting involved with community events, things like that are important. And then you got to back it up with good surgery and good outcomes or good treatments, any treatment you render. So, but the 3 A's, remember that: available, affable, and able. You follow those and you'll build a good practice. But don't be too available. You got to be available to your family too. You got to know when to draw the line. And that comes with time. It was hard for me to learn because at first I'm like just so thrilled that anyone would want to see me, for surgery. I'm like, yeah, get them in. I'll stay late, whatever. And then after a while, your staff's like, Dr. Beamer, you're killing us. We need to go home, So anyway, how was residency? Residency honestly was awesome. I did the Harvard Combined Orthopedic Surgery program. It's the only Harvard program, but it's called the Combined program because we have 4 hospitals. We got Mass General, Brigham, Beth Israel, and Children's, and we rotate through all of those. And there's 12 residents, so it's a big program, and you're not always under the same roof. So if you weren't like super self-motivated, you could easily skate by and not learn much. But if you showed interest and sought out opportunities, they were endless. And so I feel like I got the most out of it. The first year was 6 months of general surgery. That was tough, but it helped you take just a lot of sick patients, and you're on the floor. Your first year, you're not really operating much. You're just kind of rounding and learning the medical management, staying late overnight. At the very beginning of my residency is when the 80-hour work week kind of started to come out. But I remember Friday night as the intern on trauma at Mass General, you'd have the pager for all of the orthopedic inpatients. And sometimes that would be upwards of 100 patients in the hospital between the tumor service, the trauma service, the spine service, the joint replacement service. So your pager would be just going off all night. And you would have worked all day Friday, and then you're up all night answering pages, 0 sleep, and then you make rounds on Saturday morning with the team, and you clean up all the, go change all the splints and get everything ready. Well, the senior residents are taking whatever came in overnight to the OR, and there would be times where I wouldn't get out of there, till 1 o'clock on Saturday, and I started at 5 a.m. on Friday. So you're there for 36 hours, no sleep, and it's exhausting. Luckily, some of that stuff has improved, and they've been more conscientious about work hour restrictions and whatnot. But I think at some point you just got to buckle down and cut your teeth. I mean, when I'm on call, I could get called in the middle of the night and have to go do an emergency and then have a full day of elective surgery the next day. So there is some value to that, to just sucking it up and going through the suck for a year, and then it gets better. But I think that they're trying to find that balance of how much is enough and how much is too much, And then after those 6 months, then you're just all orthopedics all the time. And again, as a junior resident, usually an arthroplasty service would have a PGY2 and a PGY4. So the PGY4 would be doing a lot of clinic and operating, and the PGY2 would be doing a lot of clinic and pre and post-op management, some operating, So as you get further along, you operate more and more. But I loved it. I thought it was great. It was a good 5 years. I met my wife during that time and learned a lot. And yeah, I wouldn't trade it for anything.
Hey, Dr. Beamer. My name is Mark, I'm a first-year student. So I had a question about kind of going off your last point about kind of choosing ortho as what to apply to as a residency. You kind of touched on liking anatomy in med school. So kind of deciding between medicine versus surgery, and then specifically choosing ortho. Can you speak about, how you went about that decision process?
Yeah, for me, I've always been a hands-on guy. I like building things. I in high school, I was always in charge of our class float. I grew up building forts. I just liked working with my hands. Did some construction stuff in the summers. Just that resonated with me. So I knew I wasn't super interested in medicine. I was more interested in surgery. And again, I had shadowed a couple of surgeons in college, and I think that, kind of set my course, Um, so then why did I choose orthopedics? Again, I shadowed an orthopedic surgeon and I shadowed a general surgeon. I just like the orthopedic surgery better, and I like the idea of, taking care of not super sick people. Dealing with death and dying didn't appeal to me, and there's only a couple of fields in orthopedics where that's not dealt with regularly, or not orthopedics, rather medicine. So you start whittling it down. Okay, medicine or surgery? Okay, surgery. Okay, do I want to take care of super sick people? No. Okay, then what does that leave? And I thought the power tools and everything and fixing things and the immediate sort of like getting x-rays and looking at it and analyzing it and trying to figure out how you're going to fix it, those things resonated with me personally. Now, a lot of people could totally get satisfaction from making sure that, breast reduction is perfectly symmetric and relieves the patient's back pain, or a facial reconstruction helps with a trauma pain. It's all dependent upon like what you're into, And I think the best way to find out is to go get experiences. Go start shadowing people. Just come, if you have a half day or you're on a spring break or something, go watch some surgeries and try to really think about how you feel watching them. And if you could imagine yourself doing that and ask all the questions like that you want to ask and get them answered, but you'll never know. I mean, like, you might have this sensationalized view of what it could be, and then you get into it and you're like, wow, I really take care of a lot of old people, because a lot of old people have orthopedic problems. And you think it's going to be all athletes and weekend warriors. It's not. Little kids fall down and break their wrists, grandma falls down and breaks her hip, like it's the whole gamut. But for me, it was the immediate gratification, seeing something broke, fixing it, taking x-rays, watching it heal over the course of weeks. And then just the patience, like you really do give people their quality of life back. And like Jenny said, like I don't save lives, I save lifestyles. And if I can keep people moving and keep them active, then, people may be sound in mind, but if their body doesn't work, then they have terrible quality of life and their health suffers because of it. So I like to try to keep people moving and doing the things they want to do and enjoying whatever phase of life they're in. So for me, I find that incredibly gratifying. So that's kind of going through and thinking about, and I used to shadow plastic surgeons. I looked at urology, like I just got in there and started kind of seeing what they were doing. I thought about it on my clinical rotations, what I liked, what I didn't. Like if you hate going to work every day when you're a third year because you're on pediatrics, you're not going to be a pediatrician. You might not even be a pediatric orthopedist, So yeah, I don't know. I think just get out there and cut your teeth and kind of see what you like is the best way to figure it out. Then talk to as many people as you can.
All right, thank you.
Yeah. Any other questions? I have patients again at 1:30, so we've got about 10 minutes left. And my wife called me.
Beamer.
Hey, what's up, man?
Well, one quick question. Kind of on the school residency and life balance that you mentioned. You said it's pretty demanding. You also mentioned you met your wife during your residency, and kind of curious as to if you had a family before you went to residency or in choosing a specialty, would you have gone a different path? Now seeing how difficult the balance is, and if you decided to choose to go through it.
Yeah, no, I hear you. I had plenty of colleagues that had kids in residency or came in with kids and they did fine. They figured it out. I'm thinking of one guy in particular. He's a joint replacement surgeon down in Walnut Creek at Kaiser, a good friend of mine. His wife was also going through residency. They just figured it out. But it's not as demanding. It can be very not demanding. It's just, I just was in my beginning phases of my career building it up, so I was aggressive and I was hungry, and now that I've got like a steady stream of patients, I'm like, okay, let's dial it back, so you can work even if I know docs that work 3 days a week and still make a great living, it's as much or as little as you want. Again, you can not take call. You can get into a practice where you just do, hand surgery and you're sitting all day doing fine, not stressing your body and doing fine motor stuff and really helping people, and then not having to take hand call, just once you're done, you're done. Joint replacement doesn't have to be a lot of heavy lifting. I mean, there's ways to make it easier, but really, I mean, a lot of people do call because of either their employment situation where it's part of their contract, or if they're in private practice. And, in California, unfortunately, the contracts for reimbursement aren't awesome. So, private practice guys and gals say that a third of their income comes from their clinical practice and doing surgeries and whatnot and seeing patients in the office. A third comes from call, and a third comes from ancillary income, whether it be x-rays and DME, which is like the boots and crutches and braces, or surgery center ownership if you own shares in a surgery center. So that's your ancillary income. So call, if you decide not to take call, could mean a little bit of pay reduction because you're not going to bill as much or get a stipend for call. But hell, if it makes you happier, then can't put a price on that, So our call is not terrible. We're a level 3 trauma center. Some weekends I don't do anything. Like, I'm available, but like I don't have to go and do any surgeries, or I might do one little thing. Some week, like I remember one week in December, I cut off more body parts, toes and fingers, and it was just like an amputation fest, which I absolutely hate, right? Because I like fixing things. I don't like taking them off, but it just had to be done, So it's as hard as you want to make it. It doesn't have to be onerous. Yeah. So, I mean, like a level 1 trauma center is going to be busy. And as a matter of fact, with residency, I specifically tried to steer away from trauma heavy programs because sometimes they view the residents as cheap labor. And if there's a lot of trauma to go around, like Harborview in Seattle or UC Davis is super trauma heavy, you end up seeing a lot of trauma and you become great at it, but then you kind of miss out on the other things like sports medicine or foot and ankle or hand surgery. So I tried to find a place that was a little more balanced. But yeah, I mean, some of the more blue collar residencies where it's like more of like a lot of work and not a lot of reward would be some of the trauma heavy places. But you want to get that experience because that's the foundation of orthopedics, right? Fixing the broken bones. You don't want to be killed by it. So just be mindful of that when you apply. But yeah, I think it's totally doable. Plenty of colleagues that had kids either during or before residency. You make it work. And, especially with some of these work hour restrictions and stuff, it's not terrible.
Thank you.
Yeah, of course. Thanks for the question. All right. Well, I'm going to eat my lunch that's been sitting here on the table here. Someone else got a question? Oh, no, sorry. It went right to his little picture. Yeah. Anything else? You guys, we can do this. We can follow up in a couple months if you guys want, if you have further questions, but I got to get back to seeing patients, put a little food in my belly.
Yeah, we'll be definitely respectful of your time and let you call your wife back and get some lunch.
Yeah.
But thank you so much for joining us today. This was really helpful and really helped a lot of people get a better idea of what orthopedic surgery is actually like. So
Yeah.
Thank you so much.
Yeah, we've just scratched the surface, really. And you know what? Like, since you guys took time out of your day and you guys have shown an interest, I mean, if you ever want to come up to Sacramento and come spend a day with me in the OR, my door is always open. And Jenny can put you in contact with me and we can help coordinate that. I mean, you've come to watch surgery with me before a couple times, right, Jenny? Back when you worked at Keim?
Yeah, a couple times. I watched some arthroscopies and then also some totals. So
yeah. So
yeah.
I mean, if you guys ever want to come up and spend a day, my joint replacement day is on Monday. I do scopes on Wednesdays. I usually run 2 rooms, do like a shoulder room and a knee room, or throw in a hip scope every now and then. And then the occasional Friday, I'll do scopes or joints depending on what the demand is based on my queue of things. But feel free to, pass along my email and my cell phone to these guys if you want. And if anyone ever wants to come observe surgery or even spend a day in clinic and see what the clinical side looks like, just let me know. I have students all the time. I have a PA student with me right now for a month, actually.
I just put my email in the chat, so you can send me an email if you want to shadow Dr. Beamer at any point. But again, thank you so much for your time and for joining us. We'll talk to you soon.
Awesome.